Here is the article. I downloaded it. Surgical versus non-operative treatment for lumbar disc herniation. But I will continue on my presentation. So in a therapy article, what sections of the methodology we should pay attention to decide on the validity? This was our first point. Before all, of course, I decided that my question is answered by this article, by this publication. So that's why I decided to appraise it. Apparently, this research is giving an answer to my question. Now, I want to check whether it is valid, or how strong the recommendations are, or are they strong enough, important enough, and then is it applicable to my daily practice. So first, validity. When checking validity of this kind of articles, therapy articles, we should look at these points. The study population, because it is a randomized controlled trial, so how was the allocation process? We have to pay attention on the allocation process. Then the groups, the intervention 1 and 2, or P and I and C, intervention and comparison groups, and the outcome. Allocation. Of course, on the allocation process, the most important thing is whether it is randomized. Random allocation is not enough by itself. It should be also better concealed allocation. Without the awareness of the patient or the physician, hidden, concealed means a hidden allocation. What was this achieved? So we have to pay attention on that. Then the outcome. How was the analysis made? Did we apply an intention to treat or not? I will comment that later, intention to treat. And of course, if you have made a random allocation into the groups, then you should have fairly similar groups. So the initial patient profiles should be similar in the two groups. Did experimental and control groups begin the experiment with similar prognosis? These are the interpretations of the previous slide. Were patients randomized? Was the allocation to groups of at the time of randomization concealed? And were the patients analyzed in the groups to which they were randomized? So this is intention to treat. And were patients in the treatment and control groups similar with respect to known prognostic factors? These are the questions we have to ask ourselves. Why is it important to randomize? Because to balance known and unknown prognostic factors between the treatment arms. Because there might be confounding factors which affect our outcome. Our outcome here in this case was pain relief. So who is more sensitive for pain, woman or man? There is a difference between these two genders. Women usually are more sensitive to pain. So then if we have male and female mixed groups, we should have equal distributions of the different sexes in the different groups. What do we see if we look at the paper? If you look at this sport trial, in the method section, you have computer-generated random treatment assignment based on permuted blocks. So this was a randomly generated groupings. If you want, you may download the article and go to the method section and have a look how the groups were selected. By the way, this concealment comes before, of course. First, before treatment. First, you divide the participants into the groups, then you administer it to the therapy. So because concealed has a similar meaning like blind or unknown or hidden, people get confused and mix it with blinding. Blinding is something else, of course. First, you establish your groups by concealing, then you start applying the therapy or the control medication or the placebo, and at this stage, we prefer, of course, to have blinding. But blinding means the patient or the physician or the health professional don't know which medication, which group is receiving which therapy. So why concealment? The individual who enrolls a subject into a trial should not be aware of which arm of the study a patient will be assigned to. Similar, actually, to the therapy, but the terms used are different. When the individual who enrolls a subject should not know it, we call it a concealment. When the doctor or physician treating the patient does not know what he's doing, we call it blinding. If allocation is not concealed, patients may be systematically enrolled into one arm of the study or the other. So this causes a bias, of course, because we human beings are prone to be biased when we know which group is going to be the treatment group arm and which group will be the control arm. What is intention to treat? I have also a figure following this slide, so I hope I will be able to explain it to you in a good manner and make it understandable. The intention to treat principle states that research subjects should be analyzed in the group to which they are initially assigned, regardless of what treatment they actually receive. So you divide the participants into two groups. One group receives the intervention, the other group the control medication. And it may happen that the some of the control patients drop out. They don't take the medication, or they take they should take the placebo, but they decide to take the active medication. Or the third option, which actually we want, is they remain in the group. So whatever the case is, there are three options. Whatever the case is, we have to analyze them as they are in the group to which they are belonging to. If we decide to analyze, let's say this participant, he should be in the experimental group, take the experimental medication, but he decided not to take it. He took the control medication. So he is in the control, or he dropped out. He did not appear in the control. In this case, if we analyze him, if we make the analysis, leaving this participant out, that means here we have in this group only three participants, whereas in this group we have 4 participants. That is called analysis per protocol, because we only analyze those who followed the protocol. This is actually something very frequently done, but which is not suggested. The other option is as treated. What happens here? This participant who did not follow the protocol, who should take the experimental medication, he took the control medication. So what happened at the end? Here we have, instead of 4, here we have 5 in the control group. We have 5 participants. And in this group, we still have 3. If you do this analysis, comparing these 5 with the 3, that is called as treated. This is also sometimes, but rarely done. And the suggested type of analysis is intention to treat, which means whatever medications the participants or whatever protocol the participants have followed, we are supposed to analyze them in the groups to which they were assigned at the beginning of the research. So here we had 4 in the beginning, and in the other group also we had 4. So if you compare these 4 with these other 4s, although this one participant did not take the experimental medication, that is called intention to treat. And this is the suggested way of making the analysis. Yes, in this slide, I try to explain it in more, to make it more explanatory. Okay, in the study we found, in the sport trial, in the method section, you will see that the authors mention the analysis for the primary and secondary outcomes used all available data for each period on an intention to treat basis. They used this intention to treat approach, which is also, according to this appraisal, something good for us to trust this research. What about randomization? Either systematic or random errors may subvert the outcome of randomization. In this study, we have a table 1. Let us look at this table 1. Looking at the table 1, we see we can compare. Most studies have this table 1. They are expected to first present their descriptive findings, and you see you can compare the 2 groups. Surgery group has 232, whereas the non-operative treatment group has 240 participants. So it is from this table I can conclude, I can have an image whether this randomization was done appropriately or not. First of all, there are similar number of participants in the 2 groups. So that means the allocation into the groups was successful. Then the different demographic features like age, sex, etc., they are also comparable, you see. They are not expected to be the same, of course, because there is also the random error, but they are very similar. You can even go and perform statistical tests to see whether they are significantly different or not. But actually, if you followed an appropriate concealment allocation and randomization, then we should not worry about the differences here. These participants are 41.7 years of age. On the other group, they are 43 years of age, very similar. Here we have 101 women on the other group, also approximately similar. So that gives us an idea about the randomization. The next question we have to ask is, did experimental and control groups retain a similar prognosis after the experiment started? That is achievable by blinding the patients, participants, and the physicians or the health professionals. And the second question to ask is, did they complete the follow-up? If there are too many dropouts in one group, although you may still conduct intention to treat analysis, that will raise questions, because then I could say, hey, this group, the experimental group, there are too many dropouts. That could be because of the side effects of the medication, or because it did not work, or the participants were not happy by applying this treatment modality. So we have to ask ourselves, did experimental and control groups retain similar prognosis after the experiment started? Were patients aware of the group allocation? First allocation, huh? Then, because if it is not, we call this single-blinded. If clinicians also were not aware of the group allocations, then we call this double-blind, huh? Double-blind. Here it is single-blind. Okay, were outcome assessors aware of the group allocation? That's also important, because even at the stage of outcome assessment, we may be biased and make wrong measurements. So we could call this triple blind, but there is no term used, this triple blind, but you could imagine that it is further blind. Even the statistician or the person who is doing the analysis, and he should be blinded of the groups better. Then was follow-up complete, of course. So blinding is so important that we have to mention more about it. We have to talk more about it. Despite study design, patients, clinicians, or outcome assessors may be aware of study arm assignment. We are very curious. It is shown that the doctor is trying to look into the envelope and to see what is written in it. Is this a study group or a control group, and so on. Blinding is not always possible. Sometimes also it is not necessary. For example, if you are testing acupuncture needles, one group is receiving acupuncture, something which is physically performed, then it is very difficult, isn't it, to fake it. But in this case, you have to develop some tools, like a needle, some instrument looking like a needle, but it's actually not puncturing the skin. By this way, you can try to fake and mimic the needle and perform a blinding, but this is not always possible. Blinding becomes more important when study outcomes involves judgment, like pain, and less important when the outcome is objective and discrete, like all-cause mortality. This is placebo effect. Huh? Placebo effect. Okay. Follow-up. Status of all studied subjects should be accounted for. Subjects lost to follow-up often have a different prognosis, that is, worse prognosis, relative to study endpoints than those accounted for. So better to have no follow-up at all. We should find a way to include all participants who took the experimental medication and analyze them at the end of the study. You could give some incentives, even some cash money or some grocery coupons to promote participating and prevent loss of follow-up. Tickets for the bus or train to come to the doctor, to the follow-up visit, etc. Yes. What about our study, the sports study? In the sports study, we have this figure 1. If you go and look at the figure 1, the researchers beautifully have explained all the stages of the study. How many people were eligible? 2,700. Then which they excluded and why, and how many people they randomized here, randomization 501, and the number of people in each follow-up point, 6 weeks, 3 months, 6 months, etc., remaining in the analysis until the end of the study. And this shows us that this is very successful study because they have so many measurement points, and the study lasted 2 years. Even at the end of the 2 years, because within 2 years, so many things may happen. The participants may move to another city, they may decide not to participate, they may be sick, they may have been died, so many options. Still, they have a very similar number of participants in the 2 arms. So this is showing us that follow-up in this research was successful. Okay. Another break.